Thank you very much for the kind introduction, and it's a real privilege to be here in Edmonton and to be here at part of the forum for the Institute. Thank you to Dr. Terrell and certainly to John and the organizers for this. I'm very pleased to be able to present here on the topic of co-located integrated specialists in the community and primary care, and I hope you'll find it to be germane to the topic here of how we're going to deliver care in our community settings. So my intended talk is going to highlight three main areas. First, a bit of an overview on the background, trends and challenges that probably all of us are very well familiar with regard to the impetus for why we have to engage in these practice redesign efforts. And then I'll highlight some findings on systematic review and meta-analysis that we conducted at the Kern Center talking about this topic. And then lastly, I'll highlight some of the findings and experience that we've had in implementing a model of integrated community specialists in a primary care practice setting. So with regard to disclosures, I have none. I should note that I'm an American and my presentation should be free of alternative facts. I should probably be a bit circumspect because I'd like to go home at the end of this and make it back in the country. But nonetheless, we start off with the elephant in the room, which is that healthcare costs continue to rise inexorably. In the United States, we spend about $3 trillion, accounting for about 18% of GDP and continuing to rise. In Canada, of course, it's about $230 billion, but that trend of a percentage of GDP also continues to rise and is about 11% now as well. So in addition, when we talk about where we spend our healthcare dollars, we obviously spend them predominantly in our hospital settings and in physician and clinical services, and therefore that represents the area where we can look for opportunities to bend the cost curve and deliver high-value care. This is obviously similar here in Canada, with the exception, of course, that drug costs take up a slightly larger percentage of dollars than do physician and clinical services. Don Berwick, who was the director for the Center of Medicare and Medicaid Services back under the Obama administration, put out an article a couple of years ago and looking at an estimate of where we have waste in our healthcare system. And he estimated that between 21 and 34% of our healthcare dollars are wasted spending and due to failures in care delivery or care coordination or in problems with overtreatment, so not adhering to best practice guidelines or evidence-based medicine. So we're spending a lot of money and we're not doing so wisely. And at the same time as costs are going up, payers in our country are shifting away from traditional fee-for-service of just paying for what we do and continuing to hold us more accountable on how well we're doing it. So here's a slide that depicts the transition of fee-for-service payments that are going to be increasingly linked to quality and value through our public payer, Medicare, and you can see that for 2018, most of those payments will be linked to quality or alternative payment models with connections to value and some risk sharing. But in addition to our public payers, private payers are also doing the same thing. This is from McKesson, a consulting firm, and they surveyed about 114 insurers in the country. About a quarter of them had insured about 2 million lives or so, and the same trend is evident here, that we're going away from fee-for-service toward capitated or bundled payments that increasingly pay for performance, value, and quality. So costs are going up, the payers are not going to foot the bill, so who's going to foot the bill? Patients, those of us as consumers of healthcare. And this slide from the Kaiser Family Foundation really underscores that when you see the increase in premiums, but also the increase in the percent contribution by employees toward those premiums, and juxtaposing that against, obviously, increases in our incomes and even inflation. So as patients, as consumers of healthcare continue to have more skin in the game, as it were, they're going to increasingly, and understandably so, expect more value and more bang for their buck. So that's the economic or the financial backdrop. In terms of talking about the population, as has been alluded to, our population continues to age. In the United States, we have about 50 million Americans who are older than age 65, and by 2060, that's going to actually double to around 100 million. In Canada, the same trends are taking place, where in the next coming decades, we'll go from about 15% to about 24% of the population older than 65. And the challenge, of course, as we age, is that chronic conditions tend to go along with that. And in the United States, about half of all Americans have at least one chronic condition. And as you can see here, about a third have multiple chronic conditions. So we're talking about hypertension and hyperlipidemia, heart disease, COPD, chronic kidney disease, and the like. And of course, we know that as we have multiple chronic conditions, we're more likely to interface and interact with the healthcare system as we need more services. And so as a result, we know very clearly that those with multiple chronic conditions have greater costs associated with them, and most especially at the top. This slide here from the Agency on Healthcare Research and Quality shows that the very top percentage accounts for over a third of our total costs, and that's in line with the pyramid that Nigel had shown a little bit ago. So the reason, as we talked about, that patients have these high costs is when you have chronic conditions, they're going to tend to exacerbate. And when you have complex conditions that interrelate with one another, you're more likely to require office visits, see a physician or a care provider, perhaps go to the emergency department, go to the hospital, and require other ancillary services as well. And so you have a lot of cooks in the kitchen. And this was a study that looked at about 1 million or so, about 2 million Medicare beneficiaries. This study was in the New England Journal of Medicine. And they noted that for their average Medicare beneficiary, they had seen 2 primary care physicians, 5 specialists across 4 venues in a given year. And that, not surprisingly, if you had more conditions, you could see upwards of 16 plus physicians in a year. So those of us who interact or who are patients ourselves or see our loved ones with chronic conditions can know that there can be challenges in navigating these fragmented systems. But now I'll ask you to pivot this for just a bit and flip it. Instead of looking at it from the patient's perspective, look at it from the perspective of the PCP, the primary care physician. And there's data that suggests that the average PCP has to coordinate and interact with about 200 different specialists and providers across 100 different practice venues. So again, a lot of cooks in the kitchen, a lot of coordination effort that has to take place. And so while we have a lot of demand for healthcare, in most industries when you have high demand, you're going to get a matching supply, but in healthcare, at least in the United States, we struggle with that challenge. And interestingly, in contrast to other countries, in the United States, we have more specialists than we do have generalists or those in primary care. You can see the numbers here for the United States and also my home state of Minnesota. At the same time as we have more specialists, though, the annual number of visits to generalists is higher. So there's a tremendous strain and demand on our primary care resources. Nevertheless, we have an expected shortage on primary care providers as well as specialists, both in the medical and the surgical side. And so access remains a challenge on both sides of the coin, and should note that as these patients are getting older and getting sicker, their visits require a greater amount of intense effort to manage them. So that's the backdrop of our current system. And so I'm going to posit this point here that the primary care specialty care interface is really the key to delivering high-value care, but is beset by tremendous challenges, and I'm going to enumerate some of these in following. So first off, there's challenges with regard to communication. Primary care providers and specialists often report not getting adequate information in that exchange. And there's been a study that shows that about 70% of PCPs said that they sent appropriate information, but when you surveyed the specialists, about 30% said they got it. When you go to the other side of the coin of specialists, about 80% of the specialists say, I gave the information that the PCP needed, and about 2/3 of PCPs report having got it. So there is a mismatch and discordance in the communication stream between primary and specialty care. If you ask primary care and specialty care providers, most recognize that there's a portion of patients that don't really need to be seen. But when you drill down on a case-by-case basis, there is discordance about exactly which patients. So we're not on the same page altogether in that regard. Half of all specialty visits actually are for routine or preventative care and are visits that could therefore be done in a primary care setting. And there's data that shows that about 3/4 of all specialty visits result in a subsequent return visit. So there's this churning process going on that once patients see a specialist, they continue to see a specialist. And this is U.S. data here. So from the primary care specialty interface issue, though, as we have increased reliance and use of specialists, it can diminish effective care coordination and the role or primacy of primary care. PCPs, of course, value direct personal interaction with specialists, and they're really best suited to serve as collaborators and care coordinators rather than as competitors or gatekeepers to specialists, as was the case when we saw the previous HMO model that was originally instituted. And of course, when there are gaps in the interface, you result in medical errors, inefficient testing, delays in treatment and diagnosis and treatment, lower value, and costlier care. Again, similar to what Dr. Berwick and others had kind of commented on. So the key question for us here to answer is, how can we deliver specialty care and expertise to a population that increasingly needs it while leveraging the benefits of primary care with respect to continuity, and yet still deliver improved outcomes, a better care experience, and lower costs? So in that vein, there have been several attempts to try and engage in practice redesign efforts, and one of them that has been around for actually about 50 years now, but has gotten to the fore increasingly in the last several years, is that of the primary care medical home, recognizing the primacy of primary care and establishing, in partnership with a patient, a PCP. And you see the key features on the slide there about comprehensiveness, patient-centered focus, coordination of care, accessibility, and an attention to quality and safety. There's data that shows that primary care medical homes are associated with improved quality and some decreases in utilization and cost. There's a lot of variability because there's no one cookie-cutter model of implementing a primary care medical home. And you can see the impact as well on patient experience and on preventative care services. But as much as we focus on primary care, and primary care services really account for about 6 to 8% of total expenditures, as I just talked about, as patients age and develop more chronic conditions, they're going to need specialists. And so there is a recognition that we have to coordinate care across silos, across departments and specialties and venues to deliver care effectively in the community. And so in that vein, you have the development of the medical neighborhood paradigm, which has been around for about 10 years. And you can see the features outlined here that is predicated on bidirectional communication, coordination, and integration with the primary care medical home, that there's a focus on appropriate and timely consultations and referrals, and that essentially there is support for the PCMH, or the medical home, and the PCP as the main venue of care for those patients. So the medical neighborhood is there to support the medical home. And so to facilitate that, you have to have good neighbors. And that's a concept as well in the literature. And so we want folks who are like this. We want neighbors like Mr. Rogers. Those are the kinds of neighbors we want in our medical neighborhood. We certainly don't want someone like this, Cosmo Kramer from Seinfeld, always kind of barging in and taking the food out of the refrigerator. So the medical neighborhood is predicated on a close partnership between all the venues and providers in order for it to be successful. This is, I apologize, a little difficult to read, but Jeffrey Greenberg and others had put forward metrics that we should focus on in terms of demonstrating the value of the medical neighborhood. And they really are predicated on elements of understanding referral demand, the quality and the communication, as we talked about, which is currently suboptimal, and then also access to care, but most especially satisfaction as well, not just to patients, but to the providers who are part of this process. So in that vein of now talking about the medical neighborhood, and we're engaging in this practice redesign effort, one of the models or approaches that adopt the principles of the medical neighborhood is, rather than trying to have people still navigate multiple venues, is to bring folks into an expanded home. So you can make whatever analogy you want about the home. I had some pictures. I got rid of those because I figured the one on Seinfeld was humorous enough. And so when we talk about incorporation here in the medical home, we're talking about co-locating specialists. And this is an approach to really address some of those interface challenges I alluded to earlier. And of course, integration is a spectrum. And along that line, co-location is an advanced element of integration. And this is intended to facilitate clinical decision support, information transfer, referral quality, and tracking. So I'm going to take you through a schematic. I'm a bit of a visual person, and to try and document or explain the effect of co-location. So you start with co-located specialists in primary care. And by virtue of co-locating specialists with the primary care providers, you have opportunities for improved communication, as there is that familiarity between individuals, not just on the personal and professional level, but also with regard to practice style and understanding the population that's being served. With improved communication, you have the opportunity for enhanced care coordination through the development of shared care plans. Suddenly, as I'm taking care of a patient with heart failure, I might be able to engage my cardiologist colleague who's working with me in the same practice to be able to say, hey, how about we make this change, or I have a question about what's the next best step. So you have opportunities for enhanced care coordination and develop a shared care plan. Of course, through that proximity, you have opportunities for knowledge exchange and transfer. We know that when we have patients with a certain condition cared for by a specialist in that domain, so heart failure patients cared for by cardiologists, COPD patients cared for by pulmonologists, that those specialists do well in terms of adhering to best practice guidelines, and evidence-based medicine. But when we tend to ask the specialist to now take care of the whole patient from stem to stern, the data suggests that the generalist does a little bit better. It doesn't say that that's a hard and fast rule, but by and large, the generalist has value. And so over time, through this knowledge exchange, PCPs have an opportunity to refine their diagnostic and skill set, but also their treatment plans. And so you can see with that the opportunity to develop or create efficient testing and referrals downstream for what we need to do in terms of imaging or other investigative procedures, That in turn should lead to decreased cost. The remaining components all filter into supporting improved quality of care, which ultimately should lead to improved outcomes for patients. And then lastly, as I mentioned, the efficient testing and referrals should lead to improved access, although there is an unintended consequence potentially as we increase utilization to the PCPs, and we can talk about that in the Q&A session. But improved access by reducing unnecessary face-to-face referrals to our specialists and unnecessary testing, coupled with improved quality of care and decreased costs, should lead to an overall better care experience. And this is the triple aim that we are all striving to achieve. And one could argue that this model even supports the quadruple aim of improving provider satisfaction as well. So this is sort of the paradigm of how this effect may take place. So that's sort of the backdrop. Now I'm going to pivot to just highlighting some of the findings on a systematic review and meta-analysis that we did in conjunction with our partners in the Knowledge Synthesis Unit at the Kern Center at Mayo. And we looked at this topic here, specifically focusing on articles that had physical co-location of specialists in primary care settings. Those were the outcome measures that we really wanted to focus on. We had about 1,600 citations, and 22 of which met inclusion. Most of them were from the United States. Most of them were behavioral health models, which have been around for quite some time. I know that Dr. Armstrong had mentioned that that this was going to be a tour de force on statistics, and I apologize. I kept it just to some basic elements here, but I'll hopefully satiate anyone's interest with regard to I-squared values and some p-values there. But overall, when it came to our findings on these dimensions, we showed that patient satisfaction, provider satisfaction both improved, that waiting time for visits to the specialist decreased, and that the referral rate to those specialists also decreased. We showed that total visits increased, and this was primarily driven by total visits to the PCP, not to the specialist. And again, in a setting where we have tremendous access challenges and shortages, that's a potential unintended consequence. But one might argue that as you develop better continuity with the patient and their primary care medical home and their PCP and care team, that may be worth a trade-off that attenuates over time. We did not see an impact on hospitalization, and again, that's where we spend the bulk of our dollars, and yet we did not see that there was a tangible effect, and we can talk about that as well. For those who are statistically inclined, here are the odds ratios. You can see that out of the 22 studies, there was a paucity of studies per each of those components, and it was limited as well by significant heterogeneity, again, owing in part to the variety of different models that were implemented here. With respect to clinical outcomes, the results were mixed on those studies that talked about them, some quality of life improvements and some improvements on diabetes-related measures. And then on the 3 studies that commented on cost, 2 of which were direct to the patient, 1 was a per member per month, those 3 studies showed that there were decreasing costs associated with these models. So the summary was that co-located specialty care and primary care settings may support the aims for high-value care along the dimensions I just talked about, but the issue is that it's limited in the literature by few studies, the quality of those studies, high risk of bias, and heterogeneity of those studies. So against that backdrop, we embarked on developing an integrated community specialist model in our practice at Mayo Clinic Rochester in the employee and community health practice. And just as a quick aside on Mayo Clinic, Mayo is a large multi-specialty tertiary referral center with 3 main hubs, including the Destination Medical Center, which is situated in the original site in Rochester, Minnesota, the Midwest practice. But there are also locations in Scottsdale, Arizona, and Jacksonville, Florida, as well as an affiliated care network that provides referrals as well. But in addition to being a large referral network, we also have primary care continuity responsibilities to our community. Certainly in the Midwest practice, which is where I'm from, the area circumscribed in green is the catchment area for our population for the employee and community health practice. And so to highlight that, it's a multi-specialty primary care practice, including the divisions of pediatrics, family medicine, and internal medicine. We have about 100 primary care providers at the main site, with an additional 74 at 4 additional ones, plus a doubling of that number when you account for the trainees, all of whom have panels themselves. ECH cares for about 152,000 patients, half of whom are employees and dependents and are insured by Mayo Clinic and therefore in a vertically integrated model. So when we think about additional drivers for developing these kind of models of focusing on delivering the right care at the right time, the right place, by the right people. In this model, the physicians are salaried, and that includes our primary care providers as well as specialists, in contrast to other areas within our health system where providers are still reimbursed on a productivity basis. So that is something to note. So in addition to the ICS program, and again, the focus of our conference here is on how to build a community-based practice. These are some of the high-value care programs that we have in our employee and community health practice. An anticoagulation clinic with a home INR program to limit the number of testing that patients need to come in for through the lab. Of course, there's an additional change to try and get folks away from using Coumadin and warfarin to using the DOACs, or the novel anticoagulants. We have community health workers who help individuals navigating the health system. For those with chronic conditions, we have an adult care coordination program. For our frail elders or high-risk adults who are leaving the hospital, we have a care transitions program that have demonstrated reductions in readmissions at 30 days. We have a palliative care homebound program as well for those individuals who are too frail, with out-call lab and a support from advanced practice providers, so nurse practitioners and physician assistants. And then we have our ICS model as well, again, to try and deliver specialty expertise within the framework and the context of the medical home model. So to walk us through briefly the previous state, which is probably very familiar to those of us in this room, but certainly in the United States, a very common practice model. And we start with patients in the community, our ECH, or primary care medical home practice, and then the traditional referral practice. So you have patients who are presumably being seen by their PCP, who are then going on to the specialty practice. And for us in Rochester, even though our main practice building is literally kitty corner from our, what we colloquially call our gray building, where all the specialties are housed, even though they're literally that far away from us, and the fact that we are all Mayo employees and we share an electronic health record, there were still challenges with regard to the referral process. So did I tee up the question very clearly for what I'm asking the specialist to do? And in return, did the specialist actually answer what I was asking them to do? Did we clearly define what I'm asking for long-term management? Is it answer a specific question? Is it co-management? Am I asking them to take on primary responsibility? So there were challenges in regards to the flow of patients from the primary care medical home to the specialty practice. In addition, we had referral flow that was bypassing the medical home altogether. We have patients who are either self-referring or are being seen in the emergency department or in the hospital and then being directly referred into the specialty clinic. Once they're in the specialty clinic, there were episodes, as we talked about from the national data, of churn. So these patients would end up being seen on an annual basis. Let's say you have heart failure, you see your cardiologist every year, you may have an echocardiogram. Again, the question is this high value? And it's arguable that it may not be, but these patients were suddenly in this churning process. And then in addition, that second arrow there highlights secondary referrals. So, and I'm not picking on the cardiologists, it's just they're great colleagues, and I'll highlight cardiology and neurology in the data later on. But specialty one may be caring for a patient, and then the patient may say, well, I have this other condition. Well, I can certainly make a referral to our colleague in the other department here on a couple floors down. Sure, sounds great. But suddenly you have a disconnect of that patient with their primary care medical home and provider. So ICS, the integrated model, was really intended to begin to try and address these suboptimal referral patterns and patient flow. So with that, with the development of ICS, the objective here was, by co-locating our specialists with the primary care team, we were creating that opportunity for collaboration and coordinated care along the lines of that schematic I showed earlier. And we're really essentially putting that medical neighborhood in a co-located spot. With some operational changes with regard to patients being able to refer, as well as some interventions with regard to ED and hospital discharges, The intent here was to shift patients back to the primary care medical home. And then, if there was a need for advanced specialty care or additional specialty care, they would have a more efficient referral stream to the specialty practice in the non-co-located building. Remember, in the medical home and neighborhood, we have those specialists who are there who are delivering care to the community. So we're talking about trying to have a better yield of referrals to what we would call the top of the pyramid, so to speak. So there were those opportunities. Over time, as our program matures, the intent here would be that these streams of referral, patients being churned or being sent off for secondary referrals, would be shunted back or redirected back to the medical home, medical neighborhood model, our integrated practice. And perhaps the more exciting piece about this is a future state whereby now that we have a collaborative model of specialists working with primary care in a medical home, medical neighborhood paradigm, is opportunities to reach upstream or proactively engage our patients in the community to deliver care to subpopulations that need it to improve overall health. So that's the kind of exciting next generation sort of step with regard to these integrated practice models I would talk about there. So in terms of our ICS model at Mayo Clinic Rochester and ECH, we have co-located physicians in a couple of specialties, behavioral health, cardiology, neurology, and GI. We have co-located advanced practice providers for a couple of different specialties, notably gynecology and orthopedics. And then we leverage telemedicine modalities in a virtual model for dermatology and ophthalmology. For dermatology, we have photo apps where we're able to take a picture of a lesion that we're curious about, and within a couple of minutes, upload it into our system. We're able to pick up the phone and talk to a dermatologist who is familiar with our practice and be able to develop a shared care plan right then and there with the patient in the room, potentially obviating a need for a visit or expediting if there's a need for a biopsy or next steps in management. So the ICS model is really intended to be a stepwise consultative approach. So the first one being a curbside pager. So we have for our staff models pagers that are covered Monday through Friday. And this, of course, offers opportunities for synchronous or urgent discussion. This is really much more favored by our specialists. In the literature, there's a focus on electronic consults, which I'll talk about next, which are managed through our electronic health records inbox or email and allow for non-urgent, perhaps a little bit deeper dive. But the challenge here from the specialists is that they don't find them quite as valuable. And I'll show some data as well about the richness of the discussion that you have in a curbside consultation as opposed to an electronic consult. And then lastly, we of course have a traditional face-to-face visit, but the difference here being that the specialist is on site in the practice of the primary care setting and therefore having opportunities to see that patient in the home setting as opposed to having patients navigate multiple venues. So I'll highlight two of our ICS models and some data that we've acquired thus far. The first is on ICS neurology, and I'm going to talk about some consult typology of what was being seen and then some impact on utilization. So the first was data that we published on a pilot, an observational pilot of our ICS neurology model that included a 0.6 FTE neurologist over a 3-month period looking prospectively at consecutive consultations with a follow-up period of about 4 to 8 months. And during that time, we had 359 patients, and you can see the bulk of these interactions were actually non-visit care interactions, so curbsides and electronic consultations with about 182 face-to-face visits. There were patients who obviously generated more consultations, so this is purely just on the number of patients. And when we look at the category of diseases by referrals, these data reflect very much a traditional neurology outpatient practice, the bulk of them being headaches, followed by seizures and spells and cerebrovascular disease. Interestingly here, when we looked at, and this is the part that I find really intriguing, when you look at what was being discussed in these exchanges between curbsides and e-consults, you find that for curbsides consultation, the majority of them touched upon testing recommendations, diagnosis or diagnostic issues, and pharmacologic treatment recommendations, in contrast to the e-consults, which are obviously static exchanges, one way back and forth. So the curbside opportunity allows for a richer dialogue and an opportunity to essentially capture the entirety of the visit of what needs to be done from stem to stern. So to us, that seemed very enlightening to see that. And certainly from the standpoint, as I mentioned, of our specialists, they much more favor the curbside interaction than they do the e-consult model. We also looked at the potential for avoiding tests downstream, and we found that in our model, about a third of brain MRIs, and then the majority of EMGs, cervical MRIs, MRA or CTA head and neck, and lumbar MRIs were avoidable. So this was something that on the front end, there was consideration to order, which if not for the intervention of the neurologist engaging these providers, might have otherwise taken place. And when we followed up to see were they actually avoided, these were the numbers. And certainly in the United States, these tests and here are quite costly, both to the system, but also as well to the patient. Here is data on the referral stream. So when we look at referrals to our non-co-located practice, that's kitty corner across the street, that's reflected in blue. And compared to sort of the 3-month average beforehand, we showed a reduction overall in the number of referrals to that non-co-located practice. But most importantly here, we had about a 25% reduction in the total number of face-to-face visits, either to our ICS practice or to the non-co-located practice. And presumably this is being captured by our e-consults and our curbside. So again, avoiding face-to-face visits and the need for essentially fragmenting our care by having patients go through multiple venues. We wanted to extend our study to see, again, if this was durable. We looked at this now over the time span of a year, and we did a case control study with propensity matching to take a look at patients who went through the ICS neurology model versus the traditional model before, along those dimensions of outcomes that are listed there. And what we found was that the need for subsequent referrals to outpatient neurology were reduced when you had patients go through the ICS model, that there were definitely fewer brain MRIs and EMGs. Our EEGs were a p-value of 0.06, so were not statistically significant, but the limitation of our study was the fact that we were not really powered well for that. And interestingly here, we did not see any difference in emergency department visits, hospitalization, or wait time. And the caveats to this are that with regard to the emergency department visits and hospitalizations, we know that when patients don't have access to primary care, they don't have access to specialty care, they hit the ED and they get admitted to the hospital. So one of the concerns we had was if we implement this model and we see that reduction in utilization, are patients going to feel that they're not getting the care they need and therefore hit high cost avenues of care? And in this regard, we did not see that. Now, when we talk about bending the cost curve, this is still a limitation. So refinement of this model has to take place in order to really affect change in terms of cost downstream. The appointment wait time was interesting, but it was a limitation of how we designed our study and what data we could capture. We did not capture curbsides and e-consults, which would have otherwise reflected earlier engagement of these patients, as we had seen in our pilot model beforehand. So that was our neurology practice. Now, in contrast, I'm going to show you some data regarding our cardiology practice with regard to utilization, but also patient and provider satisfaction as well. And this was a function of the opportunity we had to do some pre-post testing before implementation. So our cardiology model employs 1.0 with a core of 5 staff, and their practice model is a mix of both scheduled and unscheduled time, similar to our neurology practice that I didn't show there. And you can see that the distribution of time is spent both for face-to-face consultation, but also non-visit care interactions with the primary care team. But also you can see the element there of ED triage. And if you remember me pointing out those referral streams of patients going from the ED or post-hospital discharge, now with this model, we're interjecting our specialists to try and do triage and determine, do these patients really need to be seen by non-co-located cardiology? Can they be seen in the cardiology ICS model? Do they need it at all? And can they otherwise be seen by the primary care provider? Or do they not need a visit at all? So that is another feature of our ICS model and is currently under investigation as well. So in contrast to neurology, we see here that we did not have a reduction in the total number of face-to-face visits. And this is an area for us in terms of further study of understanding what is it about the cardiology patients or patients being seen for cardiovascular conditions that differs from neurology that could otherwise be taken care of through non-visit care modalities. We still saw a reduction in the number of patients being sent to the non-co-located venue. So again, that creates access opportunities to that top of the pyramid if you're talking about a large integrated or tertiary referral practice. However, I should note on the x-axis, these are referrals coming from the PCP to the specialist. And you can see on the x-axis the total number is about 300. However, that's not the larger referral stream. The larger referral stream is coming from those secondary referrals or internal referrals. And in this regard here, where it's essentially a tripling, you do see a bit of a reduction over time. So as the model continues to mature, as there is a cultural change to recognizing that these community patients can actually be shunted back to the medical home because there's an ICS model in place, we're beginning to see a bit of reduction in referral utilization there. We did a provider satisfaction survey, and again, for those statistically inclined, we did paired t-test analysis for those who did surveyed on both pre and post. And here, again, remember, in the backdrop of this model is the fact that we're all Mayo employees. We're literally kitty corner across the street from our specialty colleagues. We have a shared electronic health record. And yet, at our baseline, there were elements of dissatisfaction with regard to the referral process. And yet, once we implemented our ICS model on multiple dimensions, we saw improvements with regard to access, timeliness of appointments. The timeliness is the only one that wasn't statistically significant, but did show the increase. The reason for the referral, a clear plan of communication. And then as we talk about supporting the primary care medical home, the team, here too we saw care was transitioned back to the PCP. There's a clear plan of care about when to re-refer. The third line there about referral results in duplicative testing, we wanted to see that go down. So there was a less duplicative testing under this model. Communication before any secondary referral increased, so there was better opportunity for collaboration and visit planning. And then lastly, and most importantly, transfer of knowledge was improved and overall satisfaction was improved. So the providers found this to be a worthwhile intervention, at least in our practice. We also then looked at patient satisfaction. So I've highlighted changes to utilization. We've talked about the provider satisfaction in this regard. We looked at about 500 patients on both pre and post. These were not necessarily the same patients. We had about a 60% response rate. And although we had high satisfaction at baseline along these dimensions here, we did see reductions in our satisfaction, the only one of which that was statistically significant was the time spent with the doctor. And again, as part of our ICS model, in contrast to the non-co-located practice where there would be a greater amount of time spent with those patients, the ICS model time was less. And so that may be an element that is factoring into the results from this survey. The other thing is, as much as I've talked about the importance of connecting patients to their primary care team and valuing that continuity, remember, if you're a patient who has a condition, you've been seeing your specialist every year for essentially not high-value, high-yield care, you still have a relationship with that provider. And so suddenly adopting some of these changes risks satisfaction taking a hit potentially during this transitionary period. So this was something that we were cognizant of the risk for, and yet not surprised to see. And so some final notes with regard to our ICS model. Our model was implemented with regard to the co-location piece at our largest primary care practice site at Baldwin in ECH. Again, 100 plus PCPs on site. Our model really leverages a small core of specialists within each of these ICS models. And so you develop real close partnership with the specialists and also with the PCPs. And so there's a question about the chicken and the egg. Are we attracting specialists who buy into the model of high-value care, or does the model itself change the practice style of the specialist? So it's a little hard to say which is what in terms of how this is taking effect. And then lastly, and perhaps most importantly, is the financial alignment here. As I mentioned, half of the patients we're seeing are employees and dependents, and they are insured by Mayo in a vertically insured model. Our staff are salaried and not compensated on productivity. So these are other factors that have to be considered as we talk about models such as these. So in summary, again, there are multiple trends and challenges that necessitate the development of high-value care models. Co-located specialty care in the primary care setting may have the ability to help us down the road toward achieving our triple, if not quadruple aim, and shift patients back in closer collaboration and continuity with their medical home, and then downstream, meeting patients where they're at in the community, in their home. Again, this was implemented at a primarily large practice site, so in consideration of implementing elsewhere, and there's a need for financial alignment, both in terms of reimbursement and for salaried, and you have to be aware for the potential for unintended effects during the transformation phase. I have tremendous acknowledgments for the Kern Center and certainly for the Population Health Scholar Program, my mentor, Dr. John Ebert, certainly to all the organizers here at the Institute who helped make this possible and invite me here to present today. I want to express thanks for all of you here today. I have to lastly conclude with the fact that our Minnesota Wild were eliminated right away, and I know that the Oilers have a game, so I conclude with Let's Go Oilers, and on that I thank you for listening. Thank you.